Hey guys, welcome to my video on B cell disorders. I'm going to start out by reminding you to please subscribe and click the bell icon for instant notifications of my future uploads. So B cell disorders are ones in which there's a defect or absence strictly in B cell development, and therefore T cells are not affected. The initial test if you're suspecting a B cell disorder is to take a quantitative measurement of immunoglobulin classes as well as B cell levels. Flow cytometry and molecular genetic testing are confirmatory. Bruton's X-linked AGAMMAGLOBULINEMia is when there is no B cell maturation. So in the laboratory test, there is normal pro-B or precursor, but decreased B cells and decrease of all classes of immunoglobulins. So it is caused by an X-linked defect in Bruton's tyrosine kinase. Breastfeeding confers immunity via IgG, and presentation is delayed till after 6 months. So after 6 months, there is sinopulmonary bacterial infections that are recurrent, caused by encapsulated bacteria. The way I remember this is lack of leadership or big boss forces the staff to step up high. So lack of leadership, so if there's no big boss around, B for B cell, Ig for immunoglobulin, forces the staff to step up high. So these are the three common encapsulated organisms that can be causing recurrent infections in a patient with Bruton's X-linked AGAMMAGLOBULInemia, Staphylococcus, Streptococcus, and Haemophilus, specifically Haemophilus influenzae. And another way to remember this is the only congenital immune disorder with a number in it. So actually X, which is for X-linked, can also be read as 10, but it can also be interpreted as X out, like wipe out. So there's an across-the-board decrease in all Ig classes as well as mature B cells or mature B lymphocytes. And the treatment of this is with IVIG. When we talk about defective B cell maturation, that's chronic variable immune deficiency. So you have the same types of infections in the clinical presentation as you do in Bruton's, but the age of presentation can be young adulthood, and this can be acquired. So you have lymphadenopathy and lymphocytic infiltration of organs because you have B lymphocytes, but they're not maturing properly. You cannot form plasma cells properly. The patient usually presents with autoimmune disease, so there's usually an accompanying immune thrombocytopenic purpura or a Graves' disease. The total B count is normal, but the plasma cell count is generally decreased. The levels of immunoglobulins can be normal or low. It varies from patient to patient, and the treatment is with IVIG if indeed the immunoglobulin levels are low. IgA deficiency is related to CVID. It is the most common immune deficiency, but it's often asymptomatic and presents only if there is a transfusion anaphylaxis. So if they're transfused with blood that has anti-IgA antibodies in it. If IgA deficiency is severe, it can present with chronic GI and sinopulmonary infections. This also has a strong association with autoimmune disorders, and in some cases it may progress to chronic variable immune deficiency. This, however, is not treated with IVIG, and I remember this by adult who should be anxious about anaphylaxis. So you've reached the end of my video. Please subscribe for instant updates of future uploads. Thanks for watching.